Happy Wednesday, everyone, and welcome to today's webinar, Advancing Chest Pain Care, Evidence-Based Practices, and Hospital Recognition. My name is Jana Petchak, and I am the Senior Program Development Manager for Get With the Guidelines Coronary Artery Disease, or CAD for short. Before we get started, I'd like to go over a few items so you know how to participate in today's event. The webinar is being recorded and will be sent out via email within 2 hours. There are no CEs associated with this webinar, but you may access a certificate of completion in your follow-up email after the conclusion of this event. You will have the opportunity to submit text questions by typing them into the questions pane on the control panel. You may send in your questions at any time during the presentation. We will collect these and address as many as possible during the Q&A session at the end of today's presentation. If you experience any technical issues during the webinar, most can be resolved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the GoToWebinar customer service team, whose contact information can be found in your webinar confirmation email. To view live closed captioning for this webinar, please utilize the hyperlink in the chat. Our presenter today is Dr. Kelvin Bush, who I will be introducing shortly. First, I would like to provide a brief overview of the history of AHA's Get With the Guidelines CAD program. As you can see here, Get With the Guidelines CAD is one program amongst several modules that the AHA has developed to assist hospitals in providing evidence-based care to cardiovascular and stroke patients, with the goal of improving patient outcomes, equitable patient care, increasing staff morale, and improving reimbursement and also return on investment. A little bit more about the history. We have highlighted just a few areas. In 2001, the first Get With the Guidelines program officially launched, and that was actually Get With the Guidelines Stroke. This was followed by a coronary artery disease registry and program in 2005, which was created in conjunction with the American College of Cardiology. In 2007, Mission Lifeline reporting was added to the registry, which allowed for a systems of care approach and measurements, as well as collaborating with pre-hospital providers. In 2011, new clinical practice guidelines were released around percutaneous coronary intervention, which had implications for the optimal design of STEMI systems of care. And I realized a little too late, but also in 2013, the AHA-ACC clinical practice STEMI guidelines were released, followed by the non-STEMI, non-ST elevation acute coronary syndrome guidelines in 2014. So as you can see by the history, much of the earlier history of Get With the Guidelines CAD is very focused on more of the acute coronary syndrome patient, specifically the NSTEMI and STEMI population, which are a bit more time sensitive. In 2017, the AHA relaunched Get With the Guidelines Coronary Artery Disease as a standalone registry with more targeted metrics. In 2021, the latest clinical practice guidelines around the treatment of chest pain was published and released. And in 2023, version 3 of Get With the Guidelines CAD was released, which included additional usability enhancements. And also chest pain measures were introduced for the first time as part of AHA's Rural Healthcare Outcomes Accelerator program. In 2024, a chest pain measures bundle, adapting those that were created for the Rural Health Outcomes program, were debuted for use at all sizes and types of hospitals. Which brings us to today. I am very excited that we will now be offering a Get With the Guidelines Coronary Artery Disease Hospital Chest Pain Recognition to help recognize and celebrate hospitals that have done the work to develop additional or do quality improvement work around the chest pain population. This rounds out our portfolio portfolio of hospital recognition that we have currently at the American Heart Association. For previously, the focus was, like I mentioned, on the NSTEMI and STEMI population, and we also have the Rural Outcome Healthcare Outcomes Accelerator recognition, which encompasses chest pain along with non-STEMI and STEMI populations. Why the focus on the chest pain population? Coronary artery disease is still the #1 cause of mortality globally. And in the US, every year, 6.5 million individuals present to the emergency department with acute chest pain. And until proven otherwise, for most of those patients, it has to be assumed that the cause of that could be acute coronary syndrome or another life-threatening diagnosis. So it's very important to track. Also, cardiovascular disease patients are often a hospital's most significant source of revenue. So there is a financial impact that these patients can have. And two, there's been an increasing focus on equitable care across all patient populations. And this, of course, is something that we want to be monitoring for our chest pain population as well. I'm now very pleased to introduce to you Dr. Kelvin Bush. Dr. Bush graduated from the George Washington University School of Medicine and completed an internal medicine residency and cardiology fellowship at the San Antonio Military Medical Center. He then went on to complete additional fellowship training in cardiac electrophysiology at the University of Pennsylvania. He has served on the Get With the Guidelines Coronary Artery Disease Systems of Care Advisory Committee for 4 years. He has a special interest in studying systems of care outcomes for disparate populations in cardiovascular management. He is currently the Associate Program Director and the Chief of Cardiac Electrophysiology at the San Antonio Military Medical Center and is an Associate Professor of Medicine, as well at the Uniformed Services University of Health Sciences. I'll be handing things over now to Dr. Bush. As I mentioned, he is a member of our Systems of Care Advisory Group. This is a group of clinical and quality professionals who guide us here in the AHA in the development, implementation, direction, and the evaluation of our coronary artery disease quality improvement program. So welcome, Dr. Bush.
Thank you. Thank you, thank you, thank you. If you can just give me a thumbs up, you can probably hear me now. And I will see if I have control of the slides. That was a wonderful introduction, Jana. Thank you so much. I think that you did a great job highlighting the significance of the discussion that we're talking about today. I think that before we get started, I did want to highlight that I have no disclosures, no financial disclosures, and that the discussion points I'll be talking about today are views of my own and certainly do not necessarily represent those of the American Heart Association or the American Stroke Association. And then further, the views expressed in this presentation do not reflect any of the Brooke Army Medical Center, the Department of Defense, the U.S. government, or the military in any fashion specifically. Looks like I have lost the ability. I think that when Jana, maybe you went off, I lost the ability to move the slides maybe.
Let me try again here. One moment. How about now?
There we go. Yeah, thank you. You know, in light of that conversation, right, recognizing that the sheer volume of chest pain that is presenting to emergency divisions across the United States, our goal today really is to talk about the Get With the Guidelines Registry coronary artery disease chest pain measures that have been designed really with a pointed purpose to really improve morbidity and mortality outcomes in patients presenting with chest pain. And we've designed specifically the chest pain measures in effort to really provide targeted measures for hospitals to achieve this specifically. The goal is to discuss much of the evidence and the best practices that support each of these standards, irrespective of what hospital system you're working at or what your hospital is like. And then hopefully to tie this into some real world applications and impacts these standards across the emergency departments. And so we'll try to facilitate this with a case hopefully streamed throughout the case that we can all hopefully relate to and maybe learn from, really take home many of the highlighted chest pain measures that we'll talk about today specifically. So we're here today, right, because more than 6.5 million visits to the emergency department are showing up with primary complaints of chest pain, chest discomfort, right? And we have a huge task, right, as clinicians, healthcare workers, administrators, whatever your role is, in identifying those with life-threatening pathologies and identifying those with acute coronary syndrome. This pie graph just simply graphically shows what Ms. Janin was showing previously, where there are tons of visits out there, but really only 5% of those patients are presenting with acute coronary syndrome. But we care about those patients with acute coronary syndrome specifically because of the increased morbidity and mortality that's associated with acute coronary syndrome specifically. So there's a really big spectrum of diagnoses that are a result of chest pain presentations. Patients many times can have non-cardiac chest pain etiologies, cardiac chest pain, and then there's a segment of patients presenting with acute coronary syndrome, ranging from an acute total occlusion of a coronary vessel or subtotal occlusion, right, which results in morbidity, coronary ischemia, and increased cardiovascular morbidity and mortality specifically. And so we're talking about the chest pain measures, right? Because evidence and recommendations and guideline writers have really identified these specific targets and measures and objectives to really improve outcomes specifically. We're going to talk about the role of the electrocardiogram being performed within 10 minutes of arrival. We're going to talk about the role of early cardiac troponin results within 90 minutes of arrival. We'll talk about the role of risk stratification for patients with acute chest pain or suspected acute coronary syndrome. We'll talk about the patients who are intermediate risk or those having suspected acute coronary syndrome. And then we'll talk about some updates, right, where previously patients who have been deemed low risk, right, making sure these patients actually get follow-up and maybe a little bit of a paradigm shift that's a little bit new based on newer guidelines as well. So much of what I'm going to be talking about today is coming, really 99% of what I'm going to talk about today is going to be coming from the AHA-ACC clinical practice guideline that was published by a really amazing working group led by Dr. Gulati and others and the authors there specifically, who really aimed to change a lot of our language, how we are describing chest pain, how we're evaluating chest pain, and then how we're dispelling it specifically as well. And then in accordance with the language that is provided in the recommendations, the writing group stratified each of the recommendations according to the strength of the recommendations. Class 1 meaning a strong recommendation, suggesting that a recommendation is in favor based on a therapy or an action being indicated, useful, effective, or beneficial, and that the benefit clearly outweighs the risk. And then this is all coupled with a level of evidence, whereas a level A level of evidence, right, is supported by there being high quality of evidence, meta-analysis being supportive of and suggested with high quality randomized control trials, as well as randomized control trials being corroborated by high quality registry studies, such as the Get With The Guidelines CAD registry as well. So I felt as though, in order to really drive home a lot of these points, a lot of my clinical teaching is done in the form of a case, so that we can really all be unified and really trying to see if how these chest pain measures line up with the real clinical scenario. I know that many of you may be clinicians, and so let's walk through this case together. Right, so our patient is presenting as a 41-year-old woman who presented to our emergency room in San Antonio with a background of chronic hypertension, who presented to the emergency room triage desk with shortness of breath. Right, now some of you may be thinking, wow, we are talking about chest pain today, and did Dr. Bush really just put up a case of someone with shortness of breath and not chest pain? Yeah, we did do that, definitely. And I highlighted this particular case that presented to our hospital because we know that there are certain subgroups that absolutely are notorious and well documented to present with different types of symptoms beyond chest pain that could still be very much their coronary equivalent or their anginal equivalent specifically. We know that women, we know that elderly patients, we know that diabetic patients are well documented to present with different symptoms such as shortness of breath, fatigue, malaise, abdominal pain, epigastric pain, which really should trigger clinicians to still be concerned and cautioned for making sure that they could be presenting for acute coronary syndrome specifically. Okay, and so that's maybe one of the points that I wanted to highlight from this case specifically. In the emergency room triage desk, she has vital signs done. She has a temperature of 98.4, heart rate 98 beats per minute, blood pressure 141/93. She's a little bit hypertensive. Her respiration rates are 19, and then she has saturations 96% on room air. And then in light of today's discussion, right, her symptoms prompted an electrocardiogram review. Well, why was this done? This was done, right, because, in some hospital centers, particularly ours and many others, right, there are a list of symptoms that can protocolize or prompt electrocardiogram review specifically so that we can have an ECG-guided management of one's chest pain symptoms specifically. We know that in the realm of acute coronary syndrome, it's imperative to have early diagnosis of acute coronary syndrome, particularly when it comes to cases when there's emergent revascularization needed. And so I wanted to highlight this particular case, right, where her ECG read was overall really not suggestive of any significant ischemia, infarction, injury specifically. But I did want to highlight, right, that this patient presented, and you'll notice on the left of the screen, right, that this patient presented at 1:14 in the afternoon, due to an ECG dedicated technician being located close to the triage area. The ECG was performed at 1:15 p.m., excuse me, and then due to a protocol that we have, a clinician is then provided the 12-lead ECG. And here is the documentation of the 12-lead ECG, where our clinicians are in the habit of documenting the timestamp, whether or not there's an ST segment elevation myocardial infarction. There's a time written, and so this is 13:19. In military time, this is 1:19. And so you can appreciate that 4 minutes has passed from the time of the ECG performance to the interpretation and the review, as well as the signature to show that there's a prioritization of getting the ECG performed within 10 minutes, particularly to identify high-risk findings, to identify current of injury suggestive of an ST segment elevation myocardial infarction specifically. And so at the tip of the spear in managing patients with acute coronary syndrome, it's really imperative, right, to identify these patients as soon as possible. And it really starts with the ECG. And that's one of the reasons why Class 1 recommendation is recommended for the ECG to be performed and reviewed within 10 minutes of arrival for patients presenting with suspected acute coronary syndrome, suspected chest pain, or acute chest pain syndromes specifically. And why is that imperative? It's imperative to make sure that we rule out life-threatening causes specifically, so that we can really provide ECG-directed management of chest pain syndromes specifically, which I'll further elaborate upon. You may be thinking about, some of you may have really well elaborated systems already in place, some maybe with less protocols in place, and some ways and strategies to help promote obtaining ECG interpretation within 10 minutes would include potentially establishing criteria or symptoms that would then trigger patients to receive an early ECG before clinician evaluation, designating ECG rooms and triage areas or ECG specific technicians, designing a fast track for patients with chest pain to ECG technician availability. And then, as you can imagine, right, this all really rests upon having the ability to perform ECGs and technicians or healthcare workers to perform ECGs. And so you may find yourself in a position, depending on what healthcare system you're coming from, needing to increase the training or having more ECG machines available, or actually moving the ECG acquisition area to the intake regions or the triage areas specifically. All really practical things that can be done to help improve getting ECGs performed faster, sooner, and within 10 minutes of time specifically. And so in patients presenting with chest pain, cardiovascular symptoms of which could be acute coronary syndrome, we're going to really drive home the importance of attaining a history and physical, right? We know that of the many components that are so important in evaluating patients with chest pain, the comprehensive evaluation is so important. Once that is done, the ECG really can help guide the management of chest pain for several reasons, particularly because, as you can see on the left of my screen, if you identify an ST segment elevation that is meeting STEMI criteria with a current of injury, it's not doing anyone any favors to wait on troponins, and it's really important for the patient to be revascularized emergently, or to be put in the hands of a consultative cardiologist or interventional cardiologist for emergent revascularization if a STEMI is identified. Again, to really drive home the importance of getting that ECG done up front as soon as possible to really help provide emergent vascularization in this particular scenario. In a decent subset of patients, particularly those patients who are presenting with febrile illness, presenting with coughs, presenting with pleuritic chest pain, pain that may improve upon leaning forward and worse with being in supine or on their back, and with an ECG that is really suggestive of diffuse ST segment elevations consistent with pericarditis, the ECG, again, can really guide the management of this chest pain syndrome. And in this particular case, the management of pericarditis would be really dramatically different compared to the therapies of acute coronary syndrome specifically. And so another reason why an ECG really can be really helpful and diagnostic and therapeutic for a lot of patients presenting with pericarditis. The ECG can additionally identify ST segment depressions that are suggestive of ischemia or new T-wave inversions, particularly Wellens T-waves, which are classically described as large T-wave inversions in the anterior precordial leads, really suggestive of high-risk proximate LAD disease specifically. And in these scenarios, with the right clinical context, it's really imperative to identify these patients who could have a clinical syndrome, biomarkers that are consistent with a non-ST segment elevation acute coronary syndrome. And in these scenarios, it's recommended for these patients to receive medical therapy as well as revascularization as appropriate. In a subset of patients, we may have a little bit more time, right? We may have the ability to see an ECG, kind of like our case, where there's actually a normal ECG, there's no significant findings, and particularly as we clinically evaluate patients or follow delta troponins, the role of a repeat ECG may offer more information, or the role of a posterior ECG with the leads V7 to 3.9 is incredibly reasonable with the class 2A recommendation also. And then in a small subset of patients, arrhythmias can commonly present as cardiovascular symptoms specifically. And if a patient presents with supraventricular tachycardia or atrial fibrillation or flutter or other arrhythmias, the management of the arrhythmia specifically would be most appropriate instead of empirically treating someone for acute coronary syndrome specifically. And that would also be a little more therapeutic for the patient, as you can imagine, compared to, I think, treating them for ACS. So let's come back to our patient. Let's get a little more history as she gets settled in. Remember, she's our 41-year-old female presenting with shortness of breath. We talked to her a little bit more, right? She describes the symptoms of new onset. Notice when first waking up and feeling sluggish, fatigued, planned on doing a lot of housework, yard work throughout the day, and going to work. Also, really, really busy day ahead. Now unable to really walk up flights of stairs, right? Unable to mow her lawn. She actually called into work because she was just so tired. And then she does describe, right, having a mild substernal pressure that, you know, to be honest with you, she didn't really feel it personally concerning, but I think upon your suspicion, right, it really does sound concerning, right, a little anginal in nature. And her last episode was 3 hours ago prior to her presentation specifically. So in talking about the clinical evaluation of the history, right, I want to highlight that the characteristics of one's chest pain are really important to elicit as well, recognizing that the nature, the onset, the duration, the location, whether or not the discomfort or the pain radiates, what precipitates the chest pain, relieving factors or associated symptoms are all super important to elicit. And you'll find that when we get to the discussion on the clinical decision pathways, the history really actually can give someone more points or stratify them to be low risk, high risk, or intermediate risk specifically. And so I want to highlight just the role of the history, particularly in identifying patients with angina or cardiac chest pain specifically. And so cardiac chest pain characteristics, classically described as being retrosternal, substernal in nature, precipitated by stress or exercise, discomfort that's radiating down the arm or the jaw, and then associated with dyspnea, nausea, or lightheadedness as well. And so not everyone reads the textbook for sure. And right, as clinicians, it's important to recognize that there are going to definitely be many subgroups, different people with different backgrounds, different medical histories, who are going to have different chest pain syndromes that can still be absolutely acute coronary syndrome and be very worrisome. So this is a graphic just showing that on the right, symptoms may be described as sharp, fleeting, shifting, pleuritic, positional, may be suggestive, less likely of being cardiac in etiology. And then the symptoms on the left, more substernal, central, pressure, squeezing-like sensation, gripping, heaviness, tightness, or exertional or stress-related, may be more suggestive, highly suggestive of cardiac chest pain in nature. And so the guidelines and the guidance that's been provided to us from the guideline writers really is charging us to define and describe our chest pain syndromes differently than the way that we have previously specifically. Recognizing that chest pain suggestive of ischemia is not just really a discomfort in the chest. It really can be a discomfort in the shoulder, the jaw, the epigastric area, the neck, the back specifically, and that we probably should be moving away from the terms atypical, really with the idea and recognizing that atypical may downplay one's symptoms and it may actually misinterpret as language as maybe describing one's chest discomfort as being more benign. And instead, really classifying these patients as either having cardiac, possibly cardiac or non-cardiac specifically, so that we can actually be a little more specific to the potential underlying cause and more specific to the underlying evaluation that is to move forward as well. So we have to talk about the physical examination, right? I firmly believe that it's important for us to physically, connect with our patients. In patients presenting with acute coronary syndrome, commonly, particularly depending on, I think, the severity of their acute coronary syndrome, patients can present with shock symptoms or heart failure manifested by hypotension, crackles, an S3, mitral regurgitation murmur, particularly the mitral valve apparatus is deranged or injured, or if we have a new dilatation of the left ventricle from decompensation as well. There can be some patients who actually do have a normal examination, then further evaluation, or the other portions of the clinical decision pathway may be a little more helpful in order to help stratify these patients specifically. I would charge everyone that even though this is a talk from the American Heart Association and that this is a talk on chest pain and probably a little more focused on acute coronary syndrome, that we are really charged with evaluating patients for other life-threatening causes of chest pain, such as PEs, dissections, and esophageal rupture, right? And on physical examination, patients presenting with tachycardia, dyspnea, or pleuritic chest discomfort that may tip you off to think that they may have a pulmonary embolism and then potential further imaging studies. Patients who have differentials in their pulse exams or differentials in their bilateral blood pressure measurements, tearing pain, pain radiating to the back, or syncope. This may make you concerned for an aortic dissection, something else to also be very much concerned for. Patients presenting with unilateral decreased breath sounds or patients presenting with a history of repeated emesis should really make us concerned for an esophageal or viscous rupture specifically. And the management would be really different for each of these high-risk, life-threatening findings specifically. And then it's healthy that as we evaluate these patients with chest pain, that we have really healthy differential diagnosis ranging from structural heart disease to include valvular heart disease that may be picked up from auscultation, systolic murmurs, diastolic murmurs, hypertrophic cardiomyopathy, such as a structural problem that may be listed with systolic murmurs that changes with Valsalva maneuvers, pericarditis, myocarditis, particularly in the setting of patients presenting with febrile illnesses specifically, and friction rubs, particularly for patients with pericarditis and a significant effusion. And then recognize that gastrointestinal causes, pneumonias, pneumothorax, patients can present with costochondritis as well as herpes zoster as legitimate causes of discomfort that patients are going to be presenting with. And so, it's always very humbling, to do an excellent skin exam and to identify the herpes zoster when someone has a rash, right? That's in a unilateral distribution. Or very gratifying to identify the patient who has costochondritis with a negative remainder of their workup with, excellent examination of their chest and tenderness of the costochondral joints. Or to clinically pick up a pneumothorax with the pulmonary exam, or to identify a pneumonia with patients presenting with fever, pleuritic chest discomfort, and then evidence of consolidations on physical examination as well. All really important information that can be gleaned from the bedside. So our patients, right, not really presenting with a lot of really suggestive findings. She has a really soft 2 out of 6 systolic mid systolic murmur, really benign, right, not suggestive of anything pathologic. She has clear lungs bilaterally, symmetric pulses. Her bilateral blood pressures down in the emergency room are really without significant differential. And then her jugular venous pressure, right, measured at 5 centimeters of water, really suggestive of normal right atrial pressure without evidence of right-sided filling pressures. So this brings us, right, along with the rest of our comprehensive evaluation for chest pain, to strong consideration on the role of obtaining an early cardiac troponin within 90 minutes of arrival. Why do we care about this? We care about this specifically because we know that the cardiac troponin, relative to the other labs that we obtain for routine chest pain, really is specific and unique heart muscle right? A protein that's unique heart muscle that is present if there is any heart muscle damaged from the bloodstream specifically. We are coming from a time where previously we have used the troponin I, the troponin T, the more conventional assays, and I would charge everyone to first and foremost understand what assay you have, and to first and foremost understand the power of your assay, right? With the cardiac troponins, we have learned, right, that with the high sensitivity cardiac troponins, our patients are having really, really, really great stratification, increased sensitivity and specificity for the diagnosis of acute coronary syndrome specifically. Why? Because it's detecting lower levels, right? We're also recognizing that we're able to just be very, very, very precise with identifying what the 99th percentile is as well. So a few comments about the cardiac troponin, specifically the high sensitivity troponin. It's important to understand your individual assay that you're using specifically, right? And it's important to understand what the 99th percentile of upper limit of normal is specifically, so that you can identify what is abnormal, particularly even when it comes to gender specific levels as well. We know that women tend to have lower LV mass specifically, and that may actually lead to a lower biomarker relative to men specifically. And it's important to recognize that with these high sensitivity cardiac troponins, that not only is it important to know what the upper limit of normal is, or 99th percentile, it's also important to know what is a significant delta change and what the coefficient of variation is as well, so that you can be sophisticated with the clinical management based on your troponin results specifically. And so my last point that I want to make regarding the cardiac troponins is recognizing that cardiac troponins really rely upon understanding the universal definition of myocardial infarction, and understanding that clinical symptoms coupled with signs or symptoms of ischemia or some other marker of ischemia really are what lead to the diagnosis of a myocardial infarction specifically, as lots of reasons can produce myocardial injury, heart failure. Patients with underlying coronary artery disease but not having acute coronary syndrome can lead to elevations in biomarkers suggestive of injury, which is very different to acute coronary syndrome specifically. So I'm coming back to our case, right? Our patient had a high sensitivity troponin of 36 nanograms per liter. You'll notice that the units are changing specifically. And in our lab, right, this is abnormal. This is above the 99th percentile. She had a 2-hour delta high sensitivity troponin at 39 nanograms specifically per liter, which is not a significant delta in light of her presentation, but clinically, she continues to have recurrent angina while in the emergency room, despite medical therapies, despite anti-anginal therapies specifically being directed to her. So this brings us to the use of clinical decision pathways to further stratify patients with acute chest pain and suspected acute coronary syndrome specifically, right? These have been developed, right, and is strongly recommended, right, as a chest pain measure, specifically to help provide an organized summative assessment of patients, incorporating age, ST segment changes, symptoms, right, coming back to the history that we previously discussed, coronary artery disease risk factors, and cardiac troponins, in order to estimate one's probability of acute coronary syndrome or risk of 30-day MACE specifically, right? And so not only are we identifying patients who are a higher risk and doing a better job of identifying patients with acute coronary syndrome and life-threatening things, but on the other end of the spectrum, we're also making ERs happy, disciplining patients who are really low risk, decreasing unnecessary testing, and reducing admissions, which is also really helping out a lot of healthcare systems as well. And so we've learned, right, that the high sensitivity troponin is really powerful in helping to stratify patients into low, intermediate, high risk, right, and actually be a little more predictive compared to the conventional assays as well, specifically. And so in patients presenting with acute chest discomfort, right, we discussed the role of the history and physical, the ECG. If clinical evaluation really doesn't identify any cardiac cause, right, there's a class 1 recommendation, right, for these patients to not have, right, additional cardiac testing, right, recognizing that with the high sensitivity troponins, the risk of MACE is incredibly low. And it's important to ensure that appropriate follow-up is arranged for management of the cardiovascular comorbidities specifically. In patients with possible acute coronary syndrome, right, class 1 recommendation, right, to obtain early cardiac troponins within 90 minutes. And there's a class 1 recommendation to use something called these clinical decision pathways in order to stratify patients in an organized manner so that we can then determine patients to be low risk, patients who can go home with discharge and no additional cardiac testing. Again, this is very different compared to prior conventional thinking, to identify patients who are intermediate risk, right, where we can then, discuss and, counsel our patients on the role of further diagnostic testing. And then for patients who are higher risk, right, to then counsel them on the role of invasive coronary angiography, depending on their stratification as well. So I'll talk about, these clinical decision pathways, right, that are really all endorsed by the 2021 chest pain guidelines specifically, right? You'll see on this slide that there's a lot, but I want to highlight to you that the HEART pathway, the Emergency Department Assessment Chest Pain Score, the EDAX score, the ADAP score, or the Modified Accelerated Diagnostic Protocol to assess patients with chest pain, or the no objective testing rule, or the 2020 ESC high sensitivity cardiac troponin clinical decision pathway, or the 2016 ESC GRACE score, all really are mechanisms that can be used to, for your system, your healthcare system, your clinicians to guide the clinical decision making for chest pain evaluations. I want to highlight that there are some differences that can maybe be appreciated between these different clinical decision pathways, particularly the EDAX score and the no objective testing rule. Those are predominantly a little more binary and really powered to identify most predominantly patients who are low risk, with the aim to discharge those patients in a really, really safe manner if they have lower scores, negative troponins that are not above the 99th percentile, and then clinical risk factors that are really not suggestive of anything worrisome. The HEART pathway, the ADAPT score, and the other scores will incorporate more clinical information, will in a little more thorough way identify patients to be low risk, intermediate risk, and high risk based on scoring systems specifically. I can tell you that our facility, we are in the habit and the culture of predominantly using the HEART pathway for several years. And really incorporating the more comprehensive evaluation. But really, our guidelines refer to using a clinical decision pathway that may be most appropriate for your healthcare system. And I'd encourage you to really incorporate still a really comprehensive evaluation, including really the patient's clinical evaluation. So in looking at the performance of these individual clinical decision pathways, right, you'll identify that in this row where my mouse is moving, you'll find that the ability, the sensitivity for detecting myocardial infarction is pretty good in each of the clinical decision pathways. You'll recognize that the ability to discharge patients, right, is a little bit variable, but strong. And then you'll find that particularly with the HEART pathway, with the use of high sensitivity troponins, right, we've found that we've been able to increase emergency discharges by 21%. We've been able to decrease 30-day objective testing by 12%. We've been able to decrease the length of emergency visit stays by approximately 12 hours as well. as well as with the other clinical decision pathways, there are absolutely really great highlights that can be appreciated, especially if you're coming from a healthcare system that is using another clinical decision pathway. There's a role for taking a look at the other clinical decision pathways and really doing a contrast comparison to see if how strong your current program is compared to maybe the strength of other clinical decision pathways as well. So as clinicians, right, we have to sometimes recognize that even though we may have additional amazing tests, we may have additional really great evaluations, there are some things that may just step outside of our clinical decision pathways that may trigger and may prompt us to recognize that we're dealing with someone who has really high risk chest pain features, such as really worrisome ischemic changes on ECG, really significant troponins on acute myocardial infarction, particularly a significant rise and or fall that clinically timely correlates with one's evaluation, a low ejection fraction, newly diagnosed wall motion ischemia or wall motion abnormality, and of course, a patient presenting with hemodynamic instability. This really prompt further evaluation or transfer for additional specialty care as well. Let's come back to our patient, right? So our patient, got evaluated, with the heart score specifically, and looking at the different components, for H, with her symptoms, her symptoms really concerning actually to be pretty concerning, right? So she gets 2 points for that. Her ECG, as we discussed, really not suggestive of any ECG abnormality, so 0 points for that. Her age being young, getting 0 points. Risk factors to include her chronic hypertension at baseline, and then her troponin being 1 to 3 times above the normal limit gives her a point. So she stratified as being a little bit in a more intermediate risk, even with her symptoms that she's coming in the door with. And so in taking the next step and recognizing that we now have a patient who is deemed intermediate risk, there is an important role for beginning to understand significant differences between non-invasive cardiovascular testing specifically. And so just to highlight, right, because this is a really complicated discussion, cardiac CT versus nuclear stress imaging versus stress MRI versus FFR CT versus stress echocardiography. Currently, the recommendation really is to identify and understand what test may be best for your patient, recognizing that there are limitations, strengths, and weaknesses to each of the testing modalities specifically. In patients being referred for cardiac CT, some of the benefits would offer being able to detect anomalous coronary arteries, evaluating for PEs, evaluating for aortic dissections, being able to non-invasively evaluate patients specifically, particularly patients who are unable to exercise, and referring patients for stress imaging, with the use of treadmill stress tests, with the use of PETs, with the use of stress CMR, really understanding the limitations and contraindications of those individual tests really will help guide the direction for what would be the best test. And so in patients who are intermediate risk, it's incredibly reasonable for these patients to be referred for additional testing and again to further stratify them. So our patient was referred for a cardiac CT. We have, this patient that in this cardiac CT here specifically, you can appreciate how there is a paucity of dye, particularly at the mid-LAD after this diagonal branch specifically. And you can appreciate here on further zoom up that there is evidence of soft plaques, some outward remodeling specifically concerning for higher risk disease findings specifically, and in light of having recurrent angina, in light of her having recurrent chest discomfort, in light of having symptoms that were refractory to escalating medical therapy, she was then referred for coronary angiography specifically. And then you can appreciate a correlatory cornea angiography, really highlighting a mid-LAD, really tight stenosis, highlighted by the arrow there specifically. And she underwent revascularization with cardiology specifically. So not all patients will show up similar to our patients, right? There is a huge role for taking a look at one's background imaging and prior testing specifically, particularly if the warranty and the confidence and the fidelity of information really can glean a lot of information, particularly in patients who have a recent negative test, right? There is a lot of confidence that actually can be put into that, particularly if patients are presenting with very similar symptoms for making an argument for no additional testing being done. If they're having the similar symptoms and the test with really good fidelity of information was negative. In patients with prior testing that was done, particularly if it was a stress test of some sort or some functional imaging that was inconclusive, there's a role for cardiac CT to then further stratify people. And then if there is FFR CT available, there's definitely a role for that specifically as outlined there specifically. I want to highlight that inconclusive tests really should be corroborated. And if there's unclear corroboration or identification of the underlying pathology, invasive corneography is still a class 1 recommendation for the further evaluation if there is significant inconclusive information. In patients with no prior cardiac testing, it's very reasonable to use stress testing in the form of exercise ECG, particularly patients who may not have to have additional imaging that is paired with the study specifically. Stress CMR, stress echocardiography, stress PET, stress SPECT, depending on what's available at your facility, are all incredibly reasonable in order to then further stratify patients. Cardiac CT, there's a class 1 recommendation specifically, and there's no obstructive coronary disease identified. It's reasonable for these patients to be discharged. And then if there are inconclusive findings or moderate disease findings, FFR or invasive angiography is also recommended. And so, I did want to highlight that coming out in the future and recognizing that with our clinical decision pathways and what we've learned from a lot of the literature published in patients with low risk, patients who have ruled out, patients with really just overall low risk findings and stability, that compared to what was previously a general practice, we previously had recommended cardiac testing, imaging, stress testing within 72 hours, right? But we've recognized that with really good comprehensive evaluations, that particularly coupled with the clinical decision pathways, we've learned that the 30-day risk of death and MACE is really low. And so no longer, right, is there a big push for patients to have routine admission or cardiac testing in these low-risk patients so that we can then, address other comorbidities or other etiologies for discomfort. And so this brings us to, again, highlight the Get With The Guidelines CID chest pain hospital recognition program with effort to really award, recognize, and highlight the programs, hospital centers, and healthcare systems that are really making excellent quality improvement efforts to improve outcomes along the lines of these chest pain measures that have been developed from the guidelines and the evidence. And so we are pushing and making a call and a charge, right, for ECGs to be performed within 10 minutes and early cardiac troponin results to be resulted within 90 minutes at a rate of 75% or greater to achieve the CAD chest pain hospital recognition criteria. We're also making a push and a charge, right, and a call for hospital centers, clinicians to really aim for risk stratification specifically, so that we can then further stratify the patients beyond, I think, the initial clinical evaluation. In order to obtain this plus measure, we're aiming for a goal, right, achievement score greater than 50% at the present time specifically, right? And in patients with presenting with ECGs or patients presenting with chest pain. We're looking at patients who are greater than 18 years of age. We're also able to exclude patients who may not be really fair to be graded according to this criteria, such as patients who are transferred from outside facilities or patients who had symptoms that started after their hospital arrival as well. You'll find, right, that in being transparent with our Get With The Guidelines registry information, we have power and data, right, and that we have room for improvement. And so there's definitely great information being pulled from this, but we do know that there's a great room for improvement, specifically as we see that out where our rates are currently hovering around the 60th percentile specifically. And then in looking at chest pain measure, looking at early cardiac troponin results within 90 minutes of arrival, right? We're looking at patients specifically who are coded with confirmed acute myocardial infarctions, patients with unstable angina, chest pain, patients with NSTEMIs specifically, so that we can capture how we're doing with these specific patients. As you can see here, right, here's our data from the last 2 years, specifically looking at the quarters as well. And so again, we're really aiming, to see if we can, for our patients, really meet a nice benchmark specifically at the 75% of the time in order to get the hospital recognition criteria. And then in patients, presenting with chest pain, right? Identifying the correct patients with either unstable angina or chest pain diagnoses. We're really aiming for risk stratification to be performed, right? Recognizing that there is a huge role in further evaluating patients and determining whether or not they're low risk, intermediate risk, or high risk based on additional stress testing or anatomical testing specifically. And then, as you can see here, as we're really early in the stages of really trying to change our paradigm shift, we definitely are making gains, but have plenty of room, right, for improvement in trying to improve outcomes and identify coronary disease, identify acute coronary syndrome, as well as further stratify patients who are low risk as well. So you may be asking, particularly I think if you're a hospital system or a healthcare system, how do we specifically, get graded, right? And so we definitely have volume requirements. And so if you're a chest pain center with high volumes, or if you're a chest pain center with lower volumes, less than 15, we'd ask that you have 100% of your patient population sampled. If you're a higher volume, we'd ask that, at least maybe 60 or as many patients as possible so that we can have an accurate representation. And then we'll ask specifically that patients with the following codes of unstable angina, angina not specified, chest pain, or chest pain non-cardiac really be classified and put into the pool of patients being put into the registry, specifically encounters. For those of you coming from really different hospital centers, such as urban and rural participating hospitals, they're definitely, the chest pain hospital recognition opportunity is definitely available. And we want to recognize that as we push out these chest pain measures, be on the lookout for our future tools and educational resources for quality improvement so that we can really partner with each of you to improve these outcomes and in order to actually increase the utilization of these measures specifically. And so this is my last slide, and I think that this takes us to the conclusion of my portion of this discussion. I really want to thank each of you for your attention and for attending this webinar. Hopefully you found this informative, and I think we're able to take away why we're really in this fight in order to help identify patients with high-risk chest pain syndromes, identify acute coronary syndrome, and really do our best to improve cardiovascular outcomes for our really diverse patient populations. So thank you again, and I think we'll take any questions, and I'll defer to Jana from here.
All right, thank you, Dr. Bush. And actually, seeing as we are we're almost to 2 o'clock, or depending where you're located, we're at the end of the hour. We will respond to any questions via email that folks are entering now. A couple items I do want to go over quick though before we end the webinar is just a reminder, of course, that another bonus benefit of the recognition program, of course, is that our patients, our consumers recognize the American Heart Association name, and we would love to be able to have you be able to show to your local community that you are working to improve care for the chest pain patients specifically, since it is such a very common diagnosis. And we'll give you tools to support you in that. Also, for those of you who are looking to take things a step further, we do have several different options for cardiac certification in partnership with the Joint Commission that you see here. Go ahead and scan that QR code if you'd like more information, and a member of our team will reach out to you. And also, you've heard us talk a few times now about the Rural Healthcare Outcomes Accelerator Program. This is still accepting new Get With the Guidelines facilities, all eligible rural hospitals through June 30th of 2025. It can still apply. Eligible rural hospitals can enroll in either the Get With the Guidelines CAD, stroke, and/or heart failure at no cost for 3 calendar years. If you want more information on this, go ahead and scan the QR code as well, and we'll get you in touch with one of our representatives from the rural team. All right, well, this brings us to the end. A very special thank you to Dr. Bush for delivering an excellent presentation and for your ongoing commitment to both your community and the American Heart Association. Also, to thank you to everyone who attended. Once you leave today's webinar, you will receive an email with a short survey. We would appreciate it if you would complete that to provide your feedback. You will also receive a follow-up email within 2 hours with a link to view a recording of today's webinar. On behalf of the American Heart Association and Dr. Bush, thank you for joining us today, and have a great rest of your afternoon.